Scary, I know. So what happens when your patient is too unstable to use medications for the treatment of symptomatic bradycardia? In that case, we're going to move to electrical therapy. For a third-degree AV block or other high-degree blocks, or a patient who's not responding to other treatments for symptomatic sinus bradycardia, we may have to utilize a treatment called transcutaneous pacing. The word left my mind there for a minute. So let's take a look at our monitor. And on our monitor, you see a funky, wide, slow, weird rhythm. So let's press the print button because we want to make sure that we actually know what we're looking at. Oftentimes they look very different when you print it out than it does on the monitor. So let's go over here and take a look and see what we can find. All right. So, do we have P waves? Are they upright? Do they precede each QRS complex? If you answered yes, yes, and no, you would be correct. So the problem that we have with this EKG is we do have P waves. They are upright. They are not correlating, though, with the complexes. They also have a really wide QRS complex, and it's slow. So what would you identify this rhythm as? There's no correlation between the P waves and the complexes. Absolutely, it's a third-degree AV block. So we're going to pretend like our patient is unconscious, their blood pressure is really low, they have really weak peripheral pulses, skin color is pale, they're real diaphoretic. How are we going to treat this patient? First, we already have limb leads on at minimum because we can see the EKG. We're also going to hook the defibrillator pads up to the patient. That's what this is simulating. So the same defibrillator pads that we would use to synchronize cardiovert a patient or to defibrillate a patient is what we're going to use for pacing a patient. This is called transcutaneous pacing. So the first step for transcutaneous pacing is to turn on the pacer. So we're going to take this knob and turn it to pacer. You'll see when I do that, the monitor automatically syncs. So I don't have to press the sync button when I'm pacing. The monitor automatically syncs. I now have a tick mark above each complex, and I have a few choices down here at the bottom. Start pacing, pacer rate, pacer output. We're going to choose pacer rate to begin with. Pacer rate. It's already set at 70 paces per minute. And that's a really good place to start. If you wanted to change that, you would hit this soft key and you could change that up and down. But essentially, we're going to outpace the heart is the goal in this. So that's already set good. So we're going to go ahead and start pacing. Press the start pacing button. All right. Now, I don't know if you can hear it, but the monitor is clicking. And we also have big spikes in the EKG through the isoelectric line, not just the markers on top for synchronization. That is the pacing spike. So the monitor is pacing just like an internal pacemaker would do for someone's heart, but it's going through the skin. So every time you see that big spike right there, that's the monitor shocking the patient with a little bit of energy. Okay? Now we're going to have to start increasing that energy because we have to get capture, and I'll show you what that means. So we're going to press this key that says pacer output, and we're going to start increasing the milliamps. This is not measured in joules, it's measured in milliamps. And I'm going to go ahead and skyrocket up here for a minute because normally these monitors start somewhere around 60. So we're going to pretend like this one started around 60. That's a good place to start. And what I'm looking for is on my screen there to be a complex following each tick mark. So I'm going to increase a couple of milliamps, and then I'm going to watch my monitor. Oh, there we go. So that didn't take long. Now I have a complex following each pacer spike. This is called electrical capture. So that does not necessarily mean that my patient's pulse rate matches what I'm seeing on the monitor now. So I'm going to feel, very important, the femoral pulse. The reason we feel the femoral pulse is because the patient is going to be jerking because of the energy being applied to their chest. Every time this thing shoots out energy, the patient's muscles contract. So it's a lot easier to find a pulse if you feel the femoral artery. So we're going to feel the femoral pulse, and we're going to make sure that it matches the rate, which is now 70, that we see on the monitor. If it matches the rate we see on the monitor, then we have mechanical capture. So first we obtained electrical capture, now we have mechanical capture. If I do not have mechanical capture, but I do have electrical capture, I'm going to come down here, I'm going to increase my milliamps a little bit more, and I'm going to continue to do that until I do have mechanical capture, meaning that the patient's pulse rate that I feel, I can palpate, matches what I see on the monitor. That is how you transcutaneously pace a patient.